So I hope everybody can hear and see us. I want to welcome you to the webinar organized by the EANS Peripheral Nerve Section on a very popular topic and a rising topic, which is the ulnar nerve neuropathy at the elbow. And I want to thank, of course, Deborah for organizing this excellent meeting, inviting all these very famous and noticeable speakers. And of course, I want to thank the EANS, especially Anna, for her continuous support of providing us with all that we need to have our webinar activity going on. And today my co-host will be Maria Teresa Pedro from Ulm, from Germany. And we are ready to start. So I hand over to Maria to present the first speaker. And please use the question and answer for the chat for the questions. There will be discussion, of course. This is what these webinars are living. But please, for any questions, use the chat or the question Q&A. So enjoy the evening.
Maria, you are on mute.
Okay, thank you, Christian, for the introduction. I would like to welcome Christian, who will tell us on the first part something about the anatomy to start, which is very important topic, which is actually the one of the most frequent entrapment syndromes after CTS. So Christian, we're very pleased to hear it from you, the anatomical part.
So, well, thank you very much. Good afternoon, everyone. Thank you for organizing this webinar. I will open the webinar by, as you say, describing the anatomy of the cubital tunnel, and then consequently, of course, the ulnar nerve. The cubital tunnel is a space of the dorsal medial elbow, which allows the passage of the ulnar nerve around the elbow. Its chronic compression, it's called cubital tunnel syndrome, which is basically a form of repetitive strain injury, similar to the carpal tunnel syndrome that we have at the wrist. First of all, so we're going to analyze the anatomical feature of the ulnar nerve. The ulnar nerve originates from the nerve roots C8 and T1, usually all these two, but occasionally also some C7 fibers. And then they form the medial cord of the brachial plexus. The medial cord gives off numerous branches before bifurcating into its two terminal branches, one giving the median nerve and the other becoming the origin of the ulnar nerve. As we can say in the picture, then the ulnar nerve courses down the arm medially to the brachial artery and then goes in the anterior muscular compartment up until the insertion point of the coracobrachialis muscles. Here, it pierces the medial intermuscular septum of the arm and eventually reaches the posterior muscular compartment. One common compression site is of the nerve in this point is the arcade of Struders, as we will see later. It's noteworthy to say that the ulnar nerve gives no motor or sensor branches above the elbow. At the elbow, the ulnar nerve enters then the cubital tunnel, passing posterior to the medial epicondyle, where it can be palpated by a hand. It enters then the anterior compartment of the forearm between the two heads of the flexor carpi ulnaris. The flexor carpi ulnaris is the most common sign of ulnar nerve compression. It's important to remember that. And then after this place, it travels alongside the ulna toward the ribs, staying deep to the flexor carpi ulnaris and superficial to the flexor digitorum profundus. In the distal part of the forearm, the ulnar nerve moves lateral to the flexor carpi ulnaris and then goes medially to the ulnar artery till the Guyon's canal. Here it enters the palm, superficial to the flexor retinaculum, and then once in the palm in the hand, the nerve ends with its terminal motor branches. The ulnar nerve innervates muscles in the anterior compartment of the forearm and in the hand. In the anterior forearm, the muscular branch of the ulnar nerve supplies basically two important muscles: the flexor carpi ulnaris, which flexes and abducts the hand at the wrist, and the medial half of the flexor digitorum profundus, that has the same name says, flexes the rings and the little fingers at the level of the distant interphalangeal joint. It's important to remember that the remaining muscles in the anterior forearm are innervated from the medial nerve instead. So at the hand, the majority of the intrinsic muscles are innervated by the deep branch of the ulnar nerve. Hypotenar muscles, which are the flexor digiti minimi brevis, the abductor digiti minimi, and the opponens digiti minimi, as we can say in the picture. The two medial lumbricals, the abductor pollicis, and the two interossei of the hand. The last one, the palmaris brevis, is usually an exception to this rule. It's innervated by the superficial branch of the ulnar nerve. The other muscle of the nerve, the lateral two lumbricals and the tenar eminence, are then innervated by the medial nerve. As about the sensory innervation, the ulnar nerve provides sensory innervation to the ulnar side palmar and the dorsal aspect on the hand, as well as the small finger and the ulnar half on the ring finger. There are three branches of the ulnar nerve that are responsible for its sensory innervation. Two of these arise in the forearm and then travel in the hand. The third one arises just in the hand. So the first one are the palmar cutaneous branch, which arises in the middle part of the forearm and supplies the innervation over the hypotenar eminence, so the dorsal part. And then the dorsal cutaneous branches arise about 7.5 centimeter above the wrist, goes backwards to the wrist, and then innervates the skin of the proximal part of the ulnar side of the hand, and then the ulnar, and then the last two fingers, the last 1.5 fingers. And the last branch, as we said, arises in the hand and innervates the palmar surface of these two sided fingers, as we can see in the picture. So the most frequent entrapment of the ulnar nerve are 5. The entrapment can occur in the 5 possible sites. The first is the arcade of struters that occurs approximately 10 centimeter proximal to the medial epicondyle, the medial intermuscular septum, the medial epicondyle, the cubital tunnel, that's the most frequent, and then at the level of the deep flexor pronatoral aponeurosis. As we say, the cubital tunnel is the most common. So just more specifically, the cubital tunnel syndrome is due to the compression of the ulnar nerve when it passes under the medial epicondyle on the internal portion of the elbow. In this area, the nerve is relatively unprotected and can be trapped between the bone and the skin. Even if it's not an actual bone, this spot is usually called the funny bone, because when you hit the funny bone just in the right way, you have actually hit the ulnar nerve itself. And then the impact causes the common typical sensation that probably everyone has experienced, at least one, of tingling, numbness, burning, or just pain along the inside of the arm down to the ring and the little finger. The cubital tunnel is an oval-shaped fibro-osseous space located on the posterior medial aspect of the elbow. Its ceiling is formed by the osmur ligament, that's also known as a cubital retinaculum, as we can see here in the B part, in the B circle. And the osmur ligament is a ligament passing from the medial epicondyle to the olecranon process, connecting the humeral and the ulnar heads of the flexor carpi ulnaris. In some patients, the ceiling of the cubital nerve is replaced by the unconeus epitrochlearis muscle, usually thought to be an accessory cause of ulnar nerve compression. The tunnel floor is made up by the medial collateral ligament and the elbow joint capsule, while the medial epicondyli and the olecranon form the walls at both sides. Usually, the ulnar nerve is maximal compressed between the Osborne ligament and the medial collateral ligament in the tunnel at the 100, more or less 135 degrees on the elbow flexion, when at this point the tunnel height and sagittal curvature are decreased, so it's more easy to just compress the nerve. It's usually suggests that the proximal and distal ends of the cubital tunnel can be explored carefully to prevent incomplete release by the surgery. The cubital tunnel syndrome is the most commonly reported upper extremity entrapped neuropathy. And it's the most common ulnar nerve neuropathy. It can be a result of direct or indirect trauma due to nerve vulnerability in this location. It can be classified into primary, just like, or idiopathic, it's including the anatomical variants, or secondary due to trauma, elbow arthrosis, or extra or intraneural maxes, just like lipomas or ganglions. Traction injuries can be the result of lost hanging bowing deformity. And the flexion contractures are the most common usually in trophy athletes due to extreme valgus stress that they put on the arm. Some factors leading to the common cubital tunnel syndrome include mechanical stress, direct trauma, usually repetitive elbow flexion or extension, as we said, repetitive overhead activities, or metabolic disorders, congenital deformities, joint inflammation like osteoarthritis, rheumatoid arthritis, and usually also diabetes or hemophilia. And then of recent popularization is also the concept of cell phone elbow. Then indeed doesn't need any more explanation, because I suppose anyone can understand the repetitive stress on the ulnar nerve by using the phone. Lastly, it can be important to cite another common compression site or for the nerve at the so-called arcade of Straters. It is an aportoronic band that connects the medial intermuscular septum to the medial head of the posterior triceps. The clinical significance of this structure is due to the medial nerve and brachial artery, which may pass underneath the arc formed by the process ligament over the humeral body. This ligament may also affect the ulnar nerve after an anterior transposition surgery, just to release the ulnar nerve by cubital tunnel syndrome. It's usually unlikely that the ulnar nerves are just like affected under the Struder's ligament in patients without transposition surgeries. Well, I hope I could give a nice picture of the anatomy, and I leave place to the next presenters. Thank you very much.
Dear Crescenzo, thank you very much for this excellent introduction. So I think one thing that you made very clear is that just by clinical assessment, you can clearly rule out other, or not clearly, but to a very far degree, you can rule out other pathologies, at least in terms of compression, because I think one of the main differentiation between central or spinal or proximal compression and ulnar nerve is that the ulnar nerve really sensory-wise innervates only the hand, but not the ulnar forearm. So this is what you clearly pointed out, and all the muscles involved leads to a proper assessment, clinical assessment. And so I think you laid a very, very good basis for the next presentations. So I would suggest we move on with the diagnostics to have what you presented in diagnostic imaging. And therefore, I would like to ask Kiza Rana to give his presentation, and then we will have the discussion.
Kaiser, you are on mute. Okay.
Can you guys hear me?
Yes, we can hear you now.
Thank you very much, Dr. Deborah, for inviting me to this great discussion. I will try and give you guys a little bit of an overview in terms of the role of ultrasound in ulnar neuropathy. We'll be discussing some general diagnostic imaging appearances, as well as a little bit more focus on the role of imaging when it comes to dynamic scanning. Right, so as my colleague just mentioned in the first presentation, ulnar entrapment is most common at the cubital tunnel.
Kaiser, we cannot see your slides in case. If you
Oh,
could try again.
let me try again.
Mm-hmm.
Can you guys see it?
Yes, it's uploading. Yes, if you just put on the full mode, because we still see the preview.
Let me try again.
Mm-hmm.
How about now? Can you guys see
Perfect. Yes, it's perfect.
it? Okay, it's working fine now, yeah?
Yes, absolutely.
Okay. Right, so as I was saying, ulnar nerve, the most common site of entrapment is at the cubital tunnel. There can be various causes for this. The most common site of entrapment is the cubital tunnel, and the reason for that could either be extrinsic causes or it could be mechanical movement of the nerve at the cubital tunnel. In terms of extrinsic causes, it could be post-traumatic, for example, after a fracture of the ulna. You might have some osteophytes sticking around from the side, or some metalwork which might be impinging on the nerve as it moves around. You might get periarticular ganglion cyst or soft tissue lesions, which can cause compression at the cubital tunnel. So when we scan the ulnar nerve in our practice, the ulnar nerve is scanned all the way down from the cubital tunnel down to the Guyon's canal. And it's fairly easy to identify it with ultrasound, and I will show you guys some images to help out in terms of what the normal appearance is. We will be focusing a little bit more on the hypermobility, but it's important to note that hypermobility can be a normal finding in asymptomatic individuals. So as one of our favorite phrases as a radiologist is please correlate clinically. So all of our findings, there needs to be correlated with clinical findings in terms of if the patient is actually symptomatic and whether the hypermobility is indeed the cause of the patient's symptoms. Also to note is that some movement and flattening of the nerve can be seen again in normal individuals on elbow flexion, and we'll come to that shortly. Right, so first thing, the equipment. You do need to have a decent ultrasound machine, which comes with both of these probes, which I've put in the picture. So you need to have high frequency linear probes. I prefer the the long linear probe, which with the wider bevel, purely because when the nerve is, if it's moving around and flicking around, it's easier to actually catch it in the image. The smaller one is useful in, you know, petite, thin individuals where the wide-based scanner, the probe cannot actually fit onto the patient's elbow. Patient positioning, there are different ways. There's no right or wrong way, and I tend to prefer put the patient across onto a table or a bed. The reason for that being, it provides adequate supports under the elbow, so the patient's elbow doesn't move around too much, because you do need to have that sort of stability. It does help when we're doing dynamic scanning. The other way you can do it is have the patient sit around on the other side of the bed, put a pillow under their elbow. Whatever you find most convenient, you can do that, but this is my preferred way of doing it. So we place, starting off, we place a transducer near the medial epicondyle. The nerve is assessed for normal appearance, so normal morphology, normal echogenicity. There is slight movement of the nerve on elbow flexion. When the patient flexes the elbow, the nerve moves slightly over towards the medial epicondyle, but it should not dislocate. So a little bit of movement is allowed. Frank dislocation is abnormal. And so the dynamic scanning is performed like that. The patient, and you can see putting the patient's hand on the bed does help in stabilizing it, so the probe stays completely still. So I find this particularly useful. Right, so what does a normal nerve look like? The normal appearance is there's no focal or diffuse thickening of the nerve, no movement, no significant movement on dynamic scanning, normal echogenicity, and no compressive lesion, which might be causing impingement of the nerve. The subluxation, when we describe the subluxation, basically means that the nerve moves more than what we would expect it to be normally moving on elbow flexion. So it moves more than what we expect with the normal flexion, and perches or partially dislocates, partially subluxes, but not frankly dislocates. A dislocating nerve will be, it's very easy to catch in terms of very easy to diagnose, because you will hear an abrupt palpable clicking or snapping, and you can actually see the nerve dislocate very suddenly over the medial epicondyle. So, so far in the last year, just we have scanned around 158 patients from December last year to December 2021. Out of those, 81 scans were normal. We found subluxation without frank dislocation in 43. Snapping with frank dislocation in 25 patients. Some of those were bilateral, and 9 of our patients, they showed alternate pathology, would explain either related directly or indirectly to the ulnar nerve. So a normal appearing ulnar nerve has got a typical parallel appearance of the fibers. It's mildly echogenic. On cross-sectional, the nerve is very easy to identify. It's got a honeycomb sort of appearance to it. So what we are assessing for it is that uniform caliber throughout the nerve in longitudinal section, and then no loss of any significant echogenicity of the nerve on transverse section. It's important to note that around the cubital tunnel, because of the overlying retinaculum and because of the angulation the nerve has to pass through, sometimes you do get a little bit of rounded appearance to the nerve rather than the oval appearance, which I've showed here. That is considered within normal range. So if you do find that and the patient has symptoms, then we can do other tests to confirm our diagnosis. But generally speaking, the ulnar nerve, as it passes through the cubital tunnel, it's just good to remember that it can appear a little bit more rounded than the rest of the nerve. and does appear slightly more hypoechoic than the rest of the nerves, and that can be within normal limits. Just an example of normal versus abnormal. So what happens when the nerve becomes pathological? The neuropathic nerve loses its normal echogenicity, which you can see very clearly. It becomes thickened. You lose that honeycomb pattern, and the abnormal one on this side, you can see the nerve fascicles are quite markedly thickened. So these are the signs that we look for. The thickening can be diffuse. It can be localized, depending on the pathology. Hypermobility wise, so the normal nerve will move very little around the medial epicondyle. So I'll just point out some things in here. This is the medial epicondyle. Let's see if I can bring up a pointer. So the medial epicondyle and the nerve sitting right next to it. So you see with elbow flexion, all these images have been taken with elbow flexion. With elbow flexion, there's very little movement of the nerve towards the apex of the medial epicondyle. This nerve is slightly hypermobile, and you'll see in this instance, the medial epicondyle lies here. The nerve already looks slightly hypoechoic, so we are suspecting this might be already neuropathic, and it moves slightly more towards the apex without frankly dislocating over it. And Frank's dislocation, you will see very sudden snapping of the nerve across the medial epicondyle as it crosses over. So in this particular image, the medial epicondyle is down here. This is the nerve after it has dislocated. Before flexion, it lies more posteriorly, and then it dislocates anteriorly. This is a case with bilateral, and just to show the dislocation is, when you do see it, it's quite abrupt and results in a very palpable click and snap. This particular patient, the ultrasound was very useful because we could not utilize other modalities such as an MRI. This was a post-operative patient. The patient had had previous fracture and some metal work at the in the bones, which were causing an impingement of the nerve as it crosses over. So just to point out, the nerve lies right at the top here. So there are thickened nerve bundles right at the top. These echogenic lines, they are the some of them are the broken bone fragments and some metal work underneath, and you'll see the nerve slowly catching and chafing over as it crosses over. Other pathology which we will identify includes, so this is more localized thickening of the nerve that we see in case of a neuroma. So the neuroma generally presents as a fusiform thickening of the nerve. You will have a hypoechoic appearance to the nerves, the loss of, if you remember the normal appearance, you lose the normal honeycomb appearance in cross-section, and you can see the fusiform appearance on the longitudinal section. More complicated cases can also be picked up with ultrasound, and in which case, it might not be just only hypermobility which is causing the problem. There might be other things going on. This again is a post-operative patient who developed a post-operative neuroma as well as an adjacent seroma with scar tissue. All of those were combining to give ulnar neuropathy. So the image on the right is a still image which shows what the little video is showing. So the ulnar nerve, you can see this is the normal portion of the ulnar nerve. At the abnormal bit, it is very significantly thickened. You've got scarring and soft tissue thickening around it and a persistent postoperative seroma. So all of these around the cubital fossa, which is a very tight area, can lead to ulnar neuropathy. So in summary, ultrasound is an excellent modality for ulnar nerve imaging. One of the main benefits being it's always allows dynamic assessment, which is not possible with other modalities. It's relatively quick and cheap. particularly useful in instances where other modalities cannot be utilized, such as, when you got metalwork in situ, recent surgery, or for any other reason the patient can't put the position in the MRI scanner or CT scanner. The cons obviously are it's operator dependent, so requires a lot of practice, and should always be correlated in the clinical picture, since, as I mentioned, hypermobility can be seen in asymptomatic patient. So I hope that gives you a brief overview in terms of the importance and role of ultrasound. This is a picture of our hospital. It was taken at night for two reasons, because it looks much nicer at night, and obviously it's too hot in Dubai in the morning. So that's the only time you can take a picture. Thank you very much, guys.
Thank you very much. I think you showed perfectly the advantage of ultrasound compared to MRI. And I think one of the most important thing is the dynamic aspect out of it. So moving from anatomy and morphology, we go to function, and I'm very pleased to introduce Giovanni Coco, and he will tell us something about electrophysiology. Go ahead, thank you.
Thank you, everybody. I will start to share my presentation, and I will try to do it. Okay. And the share screen, share, and I will. Can you see now?
Yes, perfectly fine.
Okay, so good evening, everybody, and I would like first of all to thank Dr. Deborah for asking me to talk at this webinar. I will try to provide some information about what can be achieved when a patient is referred with a suspicion of ulnar neuropathy to a neurophysiologist, and also to give us some idea about the limitation of this test. So ulnar neuropathy is second only to carpal tunnel syndrome as the reason why a patient is referred for a neurophysiological assessment, for an entrapment in the upper limbs. So when a neurologist approaches a patient with such a clinical suspicion, it needs to confirm or rule out the diagnosis, but also consider other conditions which can mimic the symptom of ulnar neuropathy at the elbow, such as ulnar neuropathy at the wrist, or, for example, a lower cervical radiculopathy or a lower brachial plexus lesion. Also, in some rare cases, you can also find a lesion of the ulnar nerve either in the forearm or in the proximal arm, but generally the two most common sites of compression are either at the elbow or at the wrist. So we know that the ulnar nerve origins mainly from essentially derives from the C8 and T1 roots, and eventually it arrives. It origins from the medial the medial cord of the plexus, and then it runs all through the forearm, all through the arm, without leaving any branches. So it started to provide motor branches to the flexor carpi ulnaris and the flexor digitoris profundus only in the forearm. That's the reason why, even with needle electromyography, sometimes we can only give a diagnosis of a axonal lesion of ulnar nerve proximal to the FCU. So generally, we start the neurophysiological assessment with the nerve conduction velocity. So localizing the lesion with nerve conduction study is more difficult in patients with ulnar neuropathy compared, for example, to carpal tunnel syndrome. And nerve conduction study, especially when there is an axonal loss, cannot really localize the site of the lesion. Things tend to be easier when there is some demyelination, for example, across the elbow. So how do, very quickly, nerve conduction study work? So basically, we stimulate a nerve, and then we record the sensory action potential or the motor action potential more distally. We have to, in order to calculate the velocity, we need to stimulate only one segment in a sensory nerve and at least two segments in a motor conduction velocity. So in a normal sensory or motor conduction velocity, we can see that for example, the motor action potential with its amplitude, and then we stimulate the nerve more proximally. Of course, the latency is going to be increased, and we can then measure the distance between the two sites of stimulation, and we can calculate the velocity. The machine will calculate automatically the velocity. So, for example, in the upper limbs, normally the velocity is considered normal if it is above 50 meters per second. If we have an axonal lesion, we can see that there is a drop in the amplitude. There is also, to some extent, a reduction of the velocity, but not to a major extent. Generally, it's the cutoff between a demyelinating and an axonal neuropathy in terms of reduction of the conduction velocity is considered 70% of 50 meters per second. So pragmatically, a reduction of the velocity in the upper limbs below 35 meters per second is considered to be demyelinating. However, in clinical practice, things are not so clear. There is not such a clear cutoff, and very often you find like a mixed pictures. So generally, when we approach a patient with the suspicion of the ulnar neuropathy at the elbow, we start with the conduction velocity, with a motor conduction velocity, and we record the C-map from the ADM. So we apply the recording electrode on the ADM. Of course, we need to make sure that there is a good grounding. And then we stimulate the nerve at the wrist, below the elbow and above the elbow. And what we try to find is whether there is a reduction of the conduction velocity across the elbow. And of course, we expect that the speed comes back to normal in the forearm when there is a demyelinating lesion at the elbow. So, for example, in this case, we have a patient with a ulnar neuropathy at the elbow, which is demyelinating. Why can we say that? Because the amplitude does not drop significantly, but we can see that the velocity of a segment between the distal, below the elbow and the wrist remains at 60 meters per second, and whilst between across the elbow there is a reduction of the speed of 40 meters per second. It's important when we measure the distance, the length of the ulnar nerve, that we ask the patient to flex the elbow, because if we measure the distance between the 2 points when the elbow is extended, we are going to underestimate the length of the nerve, and thus we are going to find a lower velocity, and this will cause a higher number of false positive ulnar neuropathy at the elbow. Another way to increase the sensitivity of a test is to perform a inching of the ulnar nerve. What does it mean? It means that we are going to measure the velocity along the ulnar nerve at the elbow in short segments. So generally, we stimulate at least at 4 sites below the elbow and at least 5-6 sites above the elbow. And this is something which can help us to locate the lesion either at the groove or at the cubital tunnel. This is not just a simple academic interest, but it can help, for example, the surgeon, if a surgical approach, if a surgical option is considered, to decide, for example, between a simple release versus, for example, a transposition. So how does this test appear? So, for example, we have here the inching from the ulnar nerve in a normal subject, and we can see that the latency between the different segments remains more or less normal. Whilst in this other patient with a ulnar neuropathy at the elbow, we can see that there is a sudden increment of the latency between these two segments. We can see that there is a gap between the action potential, which we can elicit with a segmental stimulation. And in this case, the inching has not only confirmed a ulnar neuropathy at the elbow, but it has localized the lesion at the level of the cubital tunnel. So even if these techniques can be technically demanding, it can give quite some important piece of information in order to decide how to manage the patient. So as I said, we start recording the motor conduction velocities at recording from the ADM. But in some patients, especially when the suspicion is very high and perhaps the motor conduction velocity recorded from the ADM are normal, we can try, for example, to record the velocities from the FDI, because especially in most of common cases, the FDI is more severely affected. This is thought to be secondary to the anatomical organization of the fibers within the ulnar nerve, and the position of the fascicle for the FDI make this muscle more susceptible to a neurodegenerative damage in case of a compression of a nerve. So regarding the sensory velocity, generally they are recorded from the fifth finger. So we apply some recording electrode in the finger, and we stimulate the ulnar nerve at the wrist. So typically, in a patient with a demyelinating lesion at the elbow, the sensory conduction velocity at the wrist remains normal. And you might wonder, okay, why don't you try to check if the sensory fiber are also affected at the elbow? Because very often they are technically difficult to perform. Conversely, we find some axonal damage at the level of a sensory fiber. It would be difficult to say whether this the lesion is located at the wrist or at the elbow. So for this reason, very often is useful to record the sensory velocity from the dorsal ulnar cutaneous nerve. So the dorsal branch of the ulnar nerve origins about 5-8 centimeters above the wrist, and it's responsible for supplying sensation in the dorsal medial hand. So we place the electrode in between the fifth and fourth digit in the dorsal web space, and then we stimulate the nerve 8 to 10 centimeters above the wrist. So in a patient with ulnar neuropathy at the wrist, we expect the dorsal ulnar cutaneous sensory study to be normal. Okay. And whilst, so if we find that this test is abnormal, this is suggestive for a lesion at the level of the elbow. However, the opposite is not always true, because again, for the organization of the fascicle within the nerve, sometimes the dorsal ulnar cutaneous sensory study could remain normal in surgically proven cases of ulnar neuropathy at the elbow. So again, to give an example, this is what the sensory conduction velocity in a patient with in a normal patient appear. So here we can see the sensory conduction velocity recording from the fifth finger, and here from the dorsal ulnar cutaneous nerve. Okay, normal amplitude, normal speed. This is what we expect to find in a patient with a ulnar neuropathy at the elbow, in which both of the amplitude are affected. So in this case, this is suggestive for a lesion proximal to the wrist. And this is what we typically find in a patient with ulnar neuropathy at the wrist. So in this case, the sensory velocity from the fifth finger are abnormal, whilst the dorsal ulnar cutaneous nerve velocity are normal. However, this picture can also be found in clinically proven cases of ulnar neuropathy at the elbow. So if abnormal, definitely suggestive for a lesion at the elbow. If normal, a ulnar neuropathy at the elbow could still be the case. So, and then we proceed to for the needle EMG. What is the role of a needle EMG? So number one is to confirm the presence of an axonal lesion. We need to remember that EMG could be completely normal in a mild demyelinating lesion. It can allow us to help us to localize the lesion, because of course, if we find some pathological signs only in the ulnar innervating muscle distally to the wrist, that makes ulnar neuropathy at the elbow unlikely. And also the needle EMG will also help to make sure that we are not overlooking any other condition which is mimicking an ulnar neuropathy, as for example, a lower tract plexopathy or a C8 radiculopathy. So that's the reason why it's important to sample other muscles which are innervated by C8, for example, typically the APB, and making sure that only the ulnar innervating muscle are affected. So the muscles which are generally checked, assessed, are the ADM, the FTP, the FDI, the flexor digitorum profundo to digit 4 and 5, and the flexor carpi ulnaris. So we normally start with the FDI, because generally is very well tolerated by the patient. The ADM is less well tolerated, but it needs to be sampled. And especially if they are found to be abnormal, we need to sample another C8T1 innervated muscle, another C8T1 non-ulnar innervated muscle, typically, for example, the APB, to make sure that we are not mixing up an ulnar neuropathy with something else. Then we move to for the needle electromyography of the ulnar innervating muscle proximal to the wrist. So it is important to notice that the flexor carpi ulnaris is either normal or minimally affected in many proven cases of ulnar neuropathy at the elbow. When we see that the SCU is severely affected, this correlates very well with the level of a compression of a nerve at the elbow. So the FTP is generally more sensitive. The reason why this happens, it could be secondary to two explanations. So one is that the fibers for the FCU are located more externally on the nerve, and so they are often spared when the nerve is compressed at the elbow. And the other reason why is because the branches for the FCU are more proximally, origin more proximally to the branches of the FDP. And because of a dying back concept of a nerve lesion, that's the reason why they are more often spared in ulnar neuropathy at the elbow, at least in the minor, in the mildest case. So what can a patient, what does a neurologist see when he sticks a needle in the muscle of a patient? So the first thing that we check is the activity at rest. So, for example, this is what we expect in a normal subject. So we insert the needle, we make some small movement within the belly of a needle. We can see some insertional activity, and this is when the operator pull the needle more inside, but otherwise the muscle remains silent. Okay, so at rest, this line remains flat. And this is what conversely can be seen in a patient in which there is some active denervation. So here the patient is not moving his muscle. The patient is at rest, but we can see some fibrillation. You can see this sharp action potential, and then we can also see these positive sharp waves. So the presence of this activity at rest is suggestive for active denervation. Then we check the activity of the muscle, asking the patient to activate the muscle. So normally we could see the motor unit action potential, and they should appear like very sharp with a clear, crisp sound, which is described by the neurophysiologist as some popcorn sound. And we can also measure, and you can also see that the number of phases is relatively small. This is conversely what happens in a muscle which has been denervated, and when some renervation has occurred. So you can see the difference. So here you can see that the motor unit potential appears to be larger. The sound is also different, and you can see that there is also a higher number of phases. So summarizing, in focal entrapment, such as ulnar neuropathy, the nerve conduction study and the EMG are useful for assessing the location, the severity, and the type of injury, typically if it is an axonal or a demyelinating lesion. We need to understand that there could be some technical limitation, and some lesion pattern can sometimes force the neurologist to give a final report of a non-localizing ulnar neuropathy. And of course, as for ultrasound, we also need to remember that clinical correlation is always required, because, for example, when we do some nerve conduction study in patients for some other condition, for example, carpal tunnel syndrome, we can find some incidental slowing, for example, at the elbow, and this is completely incidental because the patient is completely asymptomatic in this regard. And I would like to thank you for the attention.
So, dear Dr. Cocco, thank you very much for this excellent presentation and this very important enhancement of diagnostics. So now we have all the information. We know everything about anatomy and what to do now. So I'm very happy to introduce Lucas, the father of these webinars, to share his experience and opinions on what to do now with the surgical management. And after this, we will have a discussion before entering the details of the surgical techniques. Lucas, please.
Christian, thank you for these kind words. I'm not so old to be a father. I might say to consider myself more than a pioneer.
Just the webinars, just not my father.
yeah, but pioneers. One of the pioneers together with you. And congratulations to Deborah and Shimon for organizing this outstanding webinar. Of course, we are all keep on rolling in this our activity within the section for peripheral nerve surgery of EANS. And the importance of this webinar, particularly this one, is in just in terms of taking care about details for only one nerve. So this is first webinar that we are discussing in details about one nerve. Might be in future that we can continue with these webinars in taking care about details and discussion of each individual other nerves in upper extremity and lower extremity, but we'll see later. But generally speaking, my task for today is a clinical presentation and indication for surgery in ulnar nerve entrapment syndrome at the elbow, from clinical presentation to surgical management. And this is something which is very important, and in timing for surgery is also very important, as well as clear indication. I would not, let's say, take your time in repeating the anatomy after these outstanding presentations of Crescenzo and other colleagues who gave this correlation between anatomy and neuroradiological evaluation and electrophysiological evaluation. Just go through the possibility idea that there can be a multiple site of the compression of ulnar nerve with the same symptoms, which should be clearly make a differentiation in these circumstances, and then in order to make a, let's say, a clear indication, then epidemiology is also mentioned in Crescenzo presentation. There are many risk factors which are let's say, included in evolution of this very important entrapment syndrome. This might be, let's say, that residents or neurosurgeons doing this kind of surgery consider this as an easy task to do. But later on, I believe that everybody will understand that there are no easy tasks, and especially in these circumstances, all details are very important. In terms of anatomy, I would just like to stress two, in my opinion, major impact factor in final outcome of treatment of this patient. One is, of course, anatomical planes, and another one is careful preservation of sensory branches of ulnar nerve in the elbow region, and on the other thing, vascularization, which is also very important. This requires careful dissection of the ulnar nerve, and to take your time in make a clear anatomical plane in terms of preparation of the ulnar nerve. So in terms of points where ulnar nerve is can be compressed in the elbow, we heard from Crescenzo. Now we see one intraoperative photo of ulnar nerve in situ in cubital tunnel, with preserved all sensitive branches, which are not directly sensitive branches from ulnar nerve, but sensitive branches, sensory branches from other parallel nerves, which are running parallel with ulnar nerve, which also can have great impact on final outcome, especially in terms of appearing of pain after surgery, which is most important negative impact factor in quality of life of this patient after surgery, when we are talking about clear decompression of the nerve. So my message is, do not create a new nerve injuries. Take your time in clear dissection of the all nerve elements. And now we are coming to our let's say main issue of this presentation. These are symptoms and signs. Most commonly reported are paresthesia in the fifth and fourth fingers. Sensory loss is the first symptom, and clumsiness of the hand is a symptom which developed in, let's say, future. So physical examination is of outstanding importance, and you have to examine sensory function and motor function. So sensory function, usual test is 2-point discrimination test, and weakness, motor weakness should be evaluated from muscles innervated proximal to distally. Paralysis of the adductor of the thumb, impossibility of passing of the middle finger over the index finger crossing, decrease in the strength of the interosseous and flexor digitorum profundus in the 5th finger. So paresthesias are a subjective symptom. Weakness, we can see adductor of the thumb, interossal muscles, finger crossing, flexor digitorum of the 5th finger, and tinal sign. This is classical. I mean, I should not explain tinal sign in details, but it can be used in these circumstances. Wartenberg sign is also, let's say, most frequently tested, and Fromet sign, like from normal and to Fromet positive, can be useful for evaluation of this patient. So here you see in the video how it looks like one. Something from some reason cannot be open video, but generally speaking, this is one hand with suffering of ulnar nerve entrapment in the elbow. So in classifications of the symptoms, usually most frequently Dellon's classification from mild through moderate to severe is used for evaluation of this patient. So mild symptoms are intermittent paresthesia, subjective weakness. Moderate are intermittent paresthesia and measurable weakness, pinch or grip. And severe symptoms are persistent paresthesias, abnormal 2-point discrimination test, measurable weakness, atrophy, and finger crossing abnormal. Treatment options from mild to severe: mild conservative treatment, moderate surgery, severe surgery. I would just go through all this in terms of overviewing all this, because you will hear in the next presentation from Deborah and Shimon and Kartik all about this. In some circumstances, conservative treatment can give some results, but in a very early phase and with a very short duration of symptoms. Usually, patient education is very important in these circumstances to avoid provocative activities and to include physiotherapy and splints, and sometimes somebody can try with local steroid injections and analgesics. But in terms of lasting symptoms of 3 to more than 3 months, 3 to 6 months, in my opinion, when you have a moderate symptoms, this is ideal time for surgery. So surgery, there are local procedures, anterior transposition, and endoscopic procedure. You will hear the details about this. I just may put this here in order to have some kind of continuity in presentation. Also, details about anterior transposition you will hear from another presentation. This is an example that there were more than several, but these are at least 3 randomized control trials showing SD matrix results with transposition with fewer complications, simple decompression versus transposition, similar or same results. And this is how it looks like in my department in open carpal tunnel release, cubital tunnel release, simple decompression and anterior transposition. Local procedures or endoscopy. This is something what you will hear also from Kartik, who is an expert in this field, and this is just for let's say presentation continuity. Now I will show you one patient. It's a female, 40 years old. She had only symptom numbness at the level of the right wrist and 4th and 5th fingers. Duration of symptoms 9 months. She was treated at other institution, and it was performed incomplete decompression in situ, and then evaluated at our clinic 12 months following the first treatment. And the clinical findings had evolution from mild to severe. Numbness and pain at the level of the medial part of the left forearm, wrist, and 4th and 5th finger, hypertrophy of the hypotenor and interosseous muscles, impaired abduction and adduction of the fingers on the right side. Then, of course, we perform all kind of neuroradiological and electrophysiological diagnostic procedure and make a correlation with clinical findings. This was a clear indication for surgery. Then 1 month after first evaluation in our clinic, I operate this patient, and I decided to make, let's say, extended exploration, external neurolysis, complete decompression in situ with preservation of all branches of the ulnar nerve, very careful dissection, and then outcome after 9 months, there was no numbness, no weakness, no pain. And if this video is not working, I will kill my residents who prepared this presentation. But this appears in a very good functional recovery and quality of life of this patient, and this patient were very satisfied after this surgery. Unfortunately, video is not working. So what is wrong in here? This is when you prepare your let's say surgical incision, you have to be careful how you will do it. And instead of conclusion, indication for surgery should be a failure of conservative treatment, recurrent symptoms or moderates to see and or evolution of the symptoms from moderate to severe stage, nerve conduction velocity lower than 40 millimeters per second, and better postoperative results with less than 6 months of evolution of the symptomology can be expected. So timing is important, in my opinion, to operate it in this patient as soon as possible, within 3 to 6 months of the duration of symptoms. Posterior elbow trauma with neurological symptoms or signs is a clear indication, and in the case of nerve subluxation, you should use anterior transposition. So our close friend Eric Zager favorized this strategy in peripheral neurosurgery, which I use also in my department, and this is courtesy of him, this idea to promote KISS strategy, keep it simple surgeon, in terms of treatment of this patient, the essence of neurosurgery. So you should cover simply clinical history and exam are the simple foundations of diagnostic in peripheral neurosurgery. Keep the indications for surgery simple, try conservative measures, make the surgery simple, avoid complications. Neurosurgery can be done with simple basic instruments, and if you have a complication, accept it and deal it with it. So these are some tasks because we are doing our job in promoting the importance of peripheral nerve surgery in within the worldwide, especially through the low and middle income countries. These are some tasks that we are continuously working on and preparing for education of the young neurosurgeons to let's say understand and to start dealing with peripheral nerve surgery, starting from organizing live webinars and educational courses, and of course on-site education and operation with local neurosurgeons and all other educational stuff. So keep calm and raise awareness and love brachial plexus surgery. This year we will have in October 16 to 20 EANS 2020 Congress in Belgrade. I cordially invite all of you to join us. I believe that this situation with COVID-19 pandemic will be finished at least at the middle of this year, so we can join in Belgrade as in all times in full capacity. And then after that, we will have our Serbian Neurosurgical Society 8th annual meeting in December. Of course, you will all receive this information, and thank you very much for your attention. So this was my short talk.
Lucas, thank you very much. And I think we have now a lot of very interesting information, and I think too that this was somehow the idea this webinar was born on, with Deborah discussing with us the approach of what to do now. So we have everything. We have a patient with problems. We have the conduction studies. We have the imaging. We know maybe that the nerve is somehow luxating or not luxating. So what to do next? And I would like to open the discussion and ask Deborah to please have some comments on her changing of her treatment concept. So because this is where this webinar started from. Deborah, please.
Turn on your microphone, Deborah. Yeah, Deborah, turn on your
You're on mute, Deborah. We can't hear you.
Well, I mean, everybody that knows me knows that it's very infrequent that I'm muted, right? So anyway, so first of all, Happy New Year again to everybody. And I think we have quite a remarkable number of participants. So it seems that this is an interesting topic. Now, the reason why we decided that we were going to organize this webinar is because we have to admit that this is a very common pathology that is frequently encountered in neurosurgical practice, and it's not only managed by neurosurgeons. Dr. Kisa Rana and Dr. Giovanni Cocco are working with me. I have the pleasure of having their collaboration and support. And I am dealing with a lot of cases of ulnar nerve entrapment, but I'm not the only one. And there are orthopedic surgeons, there are end surgeons, there are plastic surgeons that consider that they might also treat these cases. And of course, there are controversies about the way we should do things. The reason why I wanted to do this webinar is because, especially for young surgeons starting their career, I think it's important to try to focus on which are the main course related to this pathology, and try to have good guidelines that should help them to try to give a good treatment. Now, there are a few things which have already been mentioned so far, and I think I would like to sum up that. First of all, we definitely need to have an appropriate diagnostic assessment. And I think nowadays we all agree on the fact that although electrodiagnostic studies still are part of the mainstay of the diagnostic assessment, nowadays it's not conceived anymore that you do not apply also imaging, and ultrasound has become a must in the assessment of these patients, because it's a method of study that certainly provides a lot of important information. And as I'm trying to emphasize when I'm doing my presentation, it helps a lot to try to understand the physiology of ulnar nerve neuropathy. Something else which has been very clearly highlighted is how important is the assessment with the EMG and nerve conduction study, and especially the importance of differential diagnosis. And finally, in Luca's presentation, we had an overview of the clinical presentation of these patients, of the clinical picture, and also some very important guidelines related to when we consider that we should give indication for conservative management and surgical treatment. And Luca already mentioned something that might be related to surgical technique, which is going to be developed in the second part of the webinar.
So would you go as far as saying, because it's very interesting that Kieser reminded us that without clinics, all the imaging, and Giovanni did too, with all the imaging and all the conduction studies, if you have no symptoms, nobody will touch a nerve, I guess.
Yeah, that's absolutely something that I think all agree on. We start considering that we have a clinical presentation that has to be suggestive of an ulnar nerve entrapment, and then if the diagnostic workup is basically something that we advocate in order to confirm the clinical suspicion. But I think this is a well-known concept for all of us. You do not give indication for surgery, whereas you don't have a clinical presentation which is consistent with the findings on the investigations, letting alone their electrodiagnostic or imaging. I mean, an example that I might give is that we know very well that sometimes when you have a patient studied with EMG and nerve conduction study, there might be findings which might be suggestive of a carpal tunnel syndrome, but yet the patient does not have a clinical picture related to that. And we all know that these are not cases that should be given indication for surgery.
This is something which is very important to understand for all young neurosurgeons, that symptomatology of ulnar nerve entrapment in the elbow can look like it's, easy to understand, easy to manage, easy to recognize, and easy to make, let's say, connection with clinical symptoms and find. But you should don't forget that there are possibility for double crush, even triple crush lesions with on ulnar nerve with the same symptoms. Mislead surgical indication to operate on a, let's say, wrong level. For example, this is especially when you have symptoms which is, let's say, not cleared if they are from elbow or from Guillain Canal, and that's why EMG evaluation is very important. And when you have experienced EMG evaluator, you have to keep it with you very close in order to have a correlation with the clinical findings and EMG findings. Also, ultrasound is very, very useful for this situation. And of course, I believe that Deborah and Shimon and Katrik will discuss this in their presentation. What about when you have a double side compression? When you really, let's say, establish that you have a compression on the two levels, and that this kind of compression can be treated surgically. Should you treat it surgically at the same time, or in a 2 stages procedure, and operated in the cubital tunnel and Guillain tunnel in terms of clear decompression, etc. But let's leave this discussion for the second part of our webinar.
So I think one is that we are all interdependent on each other. So the neurologist, the radiologist can only, work with the information we give, and vice versa. So it's anywhere, it's operator dependent. So of course there are, like in all fields, there are neurologists who maybe have difficulties to find a nerve once it's, for example, transposed, or to rule out the proper muscles to examine, and so on. So this is the same way as surgeons might have an incision somewhere which we are not experienced, which is not appropriate for decompression of the ulnar nerve. So we need to learn from each other, and I think the most important factor is to work together to have the best assessment possible, even if it's, let's say, just a cubital tunnel, which is not well, the most complex neuropathy we have. But if it's not assessed in a proper way by all people involved, we can do harm to patients. That was Lucas was mentioning. So you need to be careful and meticulous all the time, no matter if it's a plexus or an ulnar nerve. So what's the opinion of Giovanni and Kizer about this?
You mentioned a very good point here. Sorry, what you have, Giovanni. Basically, my assessment and the interpretation of the findings are very much, I have to address the question that the neurologist or the surgeon has put in front of me. So if I get the best information, I can give the best report out to it. If the clinical indication just says pain, then my report is going to be very generic. But if I'm provided with the right information, that the pain, and this is the likely point of compression or pathology, then I'm able to formulate a very good report, which will be useful, much more useful to the clinician than a generic report. So absolutely, you know, I mean, learning from each other, and you know, this is quite enlightening, all this session, because now I find out what you guys actually do when you poke pins into patients for nerve conduction studies and what the actual surgeries looks like. Dr. Deborah keeps sending me some gruesome pictures once in a while of the surgery she performs. But yeah, it's good to correlate what I see on ultrasound to what you guys do to the patients later.
Just one question. Can you just tell the audience how you measure your swelling? Because not each swelling is of any pathologic findings, you know. Just tell us something about the cross-sectional area and how you measure it. And
so whenever I find, so generally speaking, at the cubital tunnel, as I mentioned, the nerve does appear slightly unusual as compared to the rest of the nerve. In terms of the cross-sectional areas, there are various papers which have been published which give different measurements. But for me, the more important thing is if there is any asymmetry, if the swelling is focal or diffuse, if it is actually there is changes which would suggest that this is actually pathological rather than just the appearances of the nerve at that particular site. So I don't routinely measure cross-sectional area for ulnar nerve. For median nerves, we do. But we do, the measurement I take into account is the AP diameter, or AP cross-sectional thickness of the nerve.
And if I can make another comment is, whilst Dr. Rana is asking for more information in order to, prior to performing the ultrasound, I would suggest to the neurosurgeon to be more demanding towards the neurologist when they issue the report, in the sense that you should not be happy about just a diagnosis of ulnar neuropathy at the elbow. You should make sure that there is a standardized way of reporting, for example, the degree of severity of the compression of the lesion, for example, at the ulnar, at the elbow, the ulnar nerve. For example, there are different scales, so you would expect that the neurology will tell you, or the neurophysiology will tell you, it's a mild, moderate, or severe. For the time constraint, I would have loved to talk more at length about this topic. But for example, if there is a pure demyelinated lesion at the elbow, that is suggestive for a mild neuropathy. When you start to see some abnormality in the sensory velocities, or you start to see sign of denervation, or you start to see abnormal motor unit action potential, that is more suggestive for a more severe lesion, and then that could eventually decide to change. Or, for example, the presence of active denervation, that some neurophysiological finding can shift, for example, the choice for a conservative as opposed to a surgical management. Something like it happens, for example, in carpal tunnel syndrome, which has a grade, I use a scale, the Canterbury carpal tunnel syndrome scale, which ranges from 1 to 6. So if it is mild, moderate, or severe, if it is mild, you can say to the patient, we can try with conservative treatment. If it is severe, you say, well, it's better, especially if you see that symptoms are progressing very quickly. It's better to think sooner than later about the surgical approach.
So in routine practice, what I generally tend to do with the ulnar nerve is I'll take the AP diameter or AP size of the nerve before the cubital tunnel, at the level of cubital tunnel, and just after it. So if it shows features that would be compatible with neuropathy, then we can do further measurements as requested, or I would quote those measurements specifically, and also tend to compare it with the other side. Because as I say, sometimes it might just be, it's normal for the patient. But if it's fairly obvious in terms of sudden increase in the diameter before or after the cubital tunnel, generally with cubital tunnel syndrome, if the nerve is being compressed, just post the cubital tunnel, you will get the swelling of the nerve immediately after it. Or similarly, if there is marked flattening, then I will give the measurements at the level of the cubital tunnel and before and after it for helping in getting to the diagnosis.
Okay, so I guess we are ready to dive into surgery. We already had some teasers, and I would like to ask Shimon to kiss us, as Lucas would put it, and tell us about the simple in situ decompression. Shimon from Tel Aviv, please share your experience with us.
Yes, thank you. Nice, not here. Other lectures. Oh, I have so many lectures. Okay, it's okay. You see him?
We see all the slices, but not in the presentation mode, Shimon.
Just Shimon, put on slideshow.
It's okay now?
Again, a slideshow, because we still see the next slides.
I see.
Perfect. Now.
Thank you very much. Sorry. It's a good evening for everyone. A happy New Year, and especially healthy and successful years for everyone. The issue of this presentation is open in situ release techniques and discussion regarding advantages and maybe disadvantages of these techniques, and especially meta-analysis in compare with anterior transposition. Ulnar nerve compression at the elbow as cubital syndrome is the second most common compression in neuropathy of the upper limb. It's 25 cases per 100,000 persons, and average age is 51 years, 65 of them is male. The groove is the site of maximal nerve compression in most cases. During extension, the distance between two bony points is closed. Elbow flexions increases the strength and compression of the ulnar nerve. Surgical treatment of ulnar nerve entrapment at the elbow remains controversial. Operative treatment options include simple decompression and anterior transposition of the ulnar nerve. The debate about operative treatments is dogmatic, with trials claiming excellent results for each of the treatment options. The objective of this presentation is evaluation of the effectiveness of open in situ approach for neurovascular decompression in the treatment of cubital tunnel syndrome. Operative technique is really simple. The decision, the decompression is performed through the 5 to 6 centimeters, that's all, incision in projection of the ulnar nerve. After open of the skin, the deep fascia also is divided, and fascial root between medial epicondyle and olecranon is divided in the proximal to distal direction. The most important point from my, I think, in this approach is not only to open a nerve, it must be very careful. Why? Not only to the injured nerve, especially to preserve two small branches, flexor carpi ulnaris, and also branch to elbow joint. Because in cases of transection of these small branches, after surgery, also after successful so-called surgery, patient will be continuous suffer from intractable pain, imitated ulnar nerve entrapment. And part of the revision is in patient after in situ release will be found normal or intact nerve, but the painful neuroma in the place of these small branches. During the surgery, of course, it's better to do this with high magnification or loop or microscope, and nerve is dissected. It's not dissected circumferentially or mobilized out in this bed, Why? Because this minimizes trauma of the nerve and preserve its nutrient blood supply. But part of the supply, vascular supply, is from the bed of the nerve. For this reason, it's very important to preserve nerve in same position. It's not only to open in area as the elbow. Also, time to time, possible additional places of entrapment. It's happened not rarely. So entrapment between two muscle is flexor carpi ulnaris muscle humeral head and also flexor carpi ulnaris ulnar head in this place. And also very important during the surgery to release or decompress nerve in this area if necessary, and also to continue proximally to see this nerve is completely free. This is intraoperative electrophysiological monitoring in situ release. In part of the cases, we found increase during the surgery action potential of the nerve after a microsurgical release of the nerve. In part of the cases with anterior transposition, we found decrease of the compound muscle potential after release of the nerve. Techniques is simple and delicate, but more important because it's controversial question, what is the better approach, in situ release or anterior transposition? I investigate literature regarding a meta-analysis randomized controlled trials is compared in situ release versus anterior transposition in cases of idiopathic cubital tunnel syndrome. First meta-analysis that I found was published in 2007, was analyzed totally 361 patients. We compared simple decompression with anterior ulnar transposition. The results of this meta-analysis, no difference in motor nerve conduction velocity or clinical outcome between simple decompression and ulnar nerve transposition in patients with no prior traumatic injuries or surgical procedure involving the affected elbow. Another study, this was a very famous study from 2008. So it was investigated 490 cases for simple decompression, in similar cases for anterior transposition, and also found no statistically significant difference in surgical approaches between both studies. But there was found a trend forward to improve clinical outcome with transposition of the ulnar nerve as opposed to the simple decompression. And last study, huge study, was published in 2019, was analyzed 2,154 procedures from 70 studies, and the simple decompression versus the ulnar nerve transposition. Few results of this study. First of all, meta-analysis of clinical improvement. In meta-analysis of clinical improvement, no statistically significant difference in clinical outcome between both methods. Another meta-analysis of this study is cases of revision surgery. In cases of revision surgery, also no statistically significant difference in rate of revision surgery. Surprisingly, was results of a complication. Meta-analysis of complication in both of these methods show statistically significant difference in complication. And most of this complication is sensitive scar. This is simple decompression. This is anterior transposition. 36 compared in 4. Infection 11 in transposition 25 infection. In CRPS is only 2 cases in simple decompression and 11 cases in anterior transposition. Together is approximately 3 times more complication in anterior transposition in comparison with simple decompression. In conclusion, the open approach provides a convenient view of the ulnar nerve. One. Second, minimize the risk of nerve or vascular damage during the release. Third, allows extensive removal of adhesion, scar tissue, and fibrous bandages, followed by the vascular decompression. Simple decompression of the ulnar nerve at the elbow is a straightforward procedure for relief of paresthesias and motor symptoms caused by entrapment neuropathy of the ulnar nerve at the elbow. It has the advantages, at least morbidity, shortest recovery, and maintenance of the nerve in its anatomical location, keeping its vascular supply intact. Thank you very much for your attention.
Shimon, thanks a lot for this overview, especially for the studies. And I think we should merge directly into the next presentation of Deborah. I think I don't need to introduce you. Thanks again for organizing this webinar, Deborah, and we are looking very forward for your next talk.
So I think I'm sharing my screen. Do you see it?
Not yet.
So sorry, I have a problem because yeah, tu se mi deve fare l'update adesso.
Okay, share.
Yeah.
And it goes right.
L'ho provato poco fa, andava perfettamente.
Okay, look here.
Okay, so can you see now? Yeah.
Yes, it's perfect.
Okay. Sorry for the inconvenience of keeping you waiting. Okay, so Shimon has already started to talk about surgical technique, and he focused on simple in situ decompression, and my talk is going to be about anterior subcutaneous transposition. Now, before we go on, I would like to remind you, and this is something that was already mentioned by Lucas in his presentation, that when it comes to surgical treatment of ulnar nerve entrapment, we actually have two groups of different surgical techniques. The compressive techniques, which encompasses the simple in situ decompression that might be done with open surgery and endoscopic release, and medial epicondylectomy, that it belongs to the past because it has already been abandoned because it was related to a very high rate of complications. And then we have the so-called transposition techniques. We have three different transposition techniques. The anterior subcutaneous transposition, which is going to be the topic of this presentation, subfascial or intramuscular transposition, which is also related with a quite high rate of complications, and Lermont technique that is actually selected just in very few cases. Now, Shimon already emphasized that simple in situ decompression is considered by many like the first choice technique because it's a feasible approach, it's a simple technique, it provides an easy postoperative recovery, and also the outcome is considered extremely satisfying. But my question to you is, are we sure that simple in situ decompression is always the right choice? Because as we know, one of the main factors that affect surgical outcome is actually related to correct indication for surgery and the kind of strategy that you apply. So in trying to advocate which technique might be the best one when we compare simple in situ decompression versus anterior subcutaneous transposition, I'm going to talk again about something which has already been mentioned before, which are the physiological changes occurring during elbow flexion. Now, whenever we flex the elbow, we observe that there is a reduction in the height of the cubital tunnel, there is an increase in the endoneural pressure, there is a stretching and elongation of the nerve, and this is the factor that from our point of view is the most important one. We observe there is a medial displacement that is usually estimated as 7 millimeters, but in some cases, as Dr. Rana already explained, might be more relevant and may be related to what we call hypermobility of the ulnar nerve. Now, based on the data in the literature, hypermobility of the ulnar nerve is found in percentage ranging from 16 to 37% based on the different studies in the general population. It might be also associated to a snapping triceps, and is usually considered an asymptomatic condition. Yet we have to consider that there might be situations where hypermobility of the ulnar nerve is actually related to the onset of symptoms that might be related to a clinical picture of ulnar neuropathy. And I would like to know that nowadays, although in the past it seems that this was not an influent factor, nowadays, and probably also related to a more complete diagnostic assessment, as we do nowadays with the integration of electrodiagnostic studies and also imaging, we start to see that there might be a correlation between ulnar nerve entrapment and hypermobility of the ulnar nerve. So hypermobility might be a factor predisposing to the development of ulnar nerve neuropathy, but also there might be also evidence that there is a more severe clinical presentation. Something that we also have to emphasize as surgeons is that it seems that an hypermobility of the ulnar nerve may be something that you find spontaneously in the general population, but it's also something that can be iatrogenically triggered by simple in situ decompression. So, focusing on what was the question that we initially asked, is simple in situ decompression always the right choice? And in particular, do we still consider simple in situ decompression the first choice technique if we have a patient with hypermobility of the ulnar nerve? In the literature, there is some mention that actually when you have a iatrogenically induced hypermobility of the ulnar nerve, you have the possibility that the simple decompression is doomed to fail. And some others consider that early transposition may actually prevent this kind of complication and therefore decrease the rate of revision surgery. Now, in order to talk about these issues, I have reviewed my surgical series for the last year of practice here in UAE, since I joined Mediclinic Parkview Hospital. And therefore I started to collaborate with Giovanni and Kieser. And I have reviewed the patients between December 2020 and December 2021. And personally, I have assessed about 53 patients, prevalence of male patients, and most of them were in the age group of the third and the fourth decades that presented symptoms that might be considered clinically suggestive of an ulnar neuropathy. All my patients were studied with electrodiagnostic tests and then also with a dynamic ultrasound of the ulnar nerve at the elbow. And I always ask a bilateral study because I always want to compare both sides. Occasionally, in some specific situations, we also completed the diagnostic assessment with an MRI. Now, diagnostic workup eventually confirmed a clinical diagnosis of ulnar nerve entrapment in 39 patients out of 53. Something which I would like to emphasize is that these patients presented quite similar characteristics. Due to work or to their leisure time, they all had to spend a lot of time using electronic devices, like, for instance, smartphones. They had to do a lot of office work and therefore spending long hours typing, and especially with the lockdown, this is a situation that apparently got worse. And a peculiar feature probably of my series is that quite a high percentage of my patients were recreational weightlifters. And specifically 70% of them practice weightlifting and lifting as an average between 50 up to 120 kilograms. Of the 39 patients that I mentioned were diagnosed with ulnar nerve entrapment at the elbow, 7 of them had already been submitted to surgery. 6 patients were submitted to simple in situ decompression, and they had in 3 cases a temporary resolution of their symptoms. In 1 case, there was no change at all, and in 2 cases, there was actually a worsening of the symptoms. 1 patient had been submitted to an intramuscular transposition, and after the first surgery, he started to complain about excruciating pain, and he also presented a progressive impairment with motor and sensory deficits. Now, talking about the overall pool of patients, it's interesting to note that the percentage of patients that presented hypermobility of the ulnar nerve in this series is 70%. Therefore, remarkable higher of the percentage up to 37, which has been reported to occur in the general population. So if we compare this data, we would say that it seems that hypermobility of the ulnar nerve seems to be a major factor in predisposing to the onset of ulnar neuropathy. So following more or less the guidelines that Lucas already mentioned before, we designed what kind of treatment we are going to indicate for these patients. 25 were given indication for conservative management, and 14 patients underwent surgery. And it's interesting to note that out of the 14 patients that were given indication for surgery, 10 of them presented an associated hypermobility of the ulnar nerve. And specifically, 8 primary cases presented hypermobility of the ulnar nerve, whereas 2 of the cases of revision surgery had developed had presented an hypermobility of the ulnar nerve, which I do not know whether it was a pre-existing condition before the first surgery, because these patients were operated without a pre-op ultrasound. So I would say that these are cases if you have a tendency to subluxation, or if you have a frank dislocation, so if you have an hypermobility of the ulnar nerve, simple in situ decompression is probably not your best technical choice, and you should go for an anterior subcutaneous transposition. And this is a concept that also Lucas emphasized at the end of his presentation. So I am briefly mention here which are the main steps to perform a correct anterior subcutaneous transposition. Of course, we have to perform a decompression of the ulnar nerve along its course, taking care of decompressing the nerve in the cubital tunnel, but also in between the 2 heads of the flexor carpi ulnaris. It's essential to carefully prepare the branches for the flexor carpi ulnaris. A major step is always to take care of resecting the intermuscular septum, because in cases of anterior subcutaneous transposition that failed, very often on revision surgery, it was documented that the intermuscular septum had not been resected, and this eventually created a secondary kinking of the nerve. And then you can mobilize the nerve, which is going to be, as we are going to see, fixing the new domicile. And some others also recommend an excision of the offending snapping medial portion of the triceps in case of an association of snapping triceps. Now, these are surgical videos that show the presence of a snapping ulnar nerve that you can see before the Osborne aponeurosis was resected. And this clearly shows how after opening the cubital tunnel, the frank dislocation becomes even more evident. This is a situation that, if it is not further treated with an anterior subcutaneous transposition, is certainly not going to sort out the symptoms of the patient. Now, the interesting thing is that out of the 14 cases I mentioned before, one of my patients also presented a complete lack of Osborn's aponeurosis. This is a finding that I already found in a couple of cases in patients I operated in the past years in the UAE. It's very important to pay attention to the cutaneous branches that you find, because otherwise, as Shimon correctly mentioned, damaging these cutaneous branches may expose to the development of a neuroma that can partially compromise the valid functional outcome of your surgery. And it's always very important to identify, isolate, and carefully mobilize the branches for the flexor carpi ulnaris. This surgery should always be performed under magnification. There is also something I would like to mention. Usually it is believed that the ulnar nerve is starting to branch off at the level of the flexor carpi ulnaris, but I think it's an experience of all of us that occasionally there might be also some branching for the triceps above the level of the elbow. The nerve is then transposed. As I said, we also have to pay attention to resect the intermuscular septum to prevent a further kinking of the nerve at this site. And then in order to prevent that there is a slipping of the ulnar nerve back into the empty groove, we prepare a sling of fat tissue, which is going to maintain the nerve in the new domicile. And this is the final picture. In case of a snapping triceps, which is a situation that I happen to find in very few cases and not in the small group of patients that I have reviewed for this webinar, it is suggested that you should also perform a lateral transposition or excision of the offensive snapping medial portion of the triceps. And Robert Spinners, for instance, specifically highlights that this might be actually a situation that favors the failure of your outcome if you do not also apply this step. So talking about the outcome of my patients, I have to say that first of all, the patients I examined in these cases were just operated in this last year. So of course, follow-up is not probably long enough, but so far all patients presented a satisfactory outcome. The conclusion is that we really have to consider that hypermobility of the ulnar nerve may be a major factor that predisposes to ulnar nerve entrapment. And there is something that I would like to emphasize. It might be that nowadays we have a lifestyle change that might actually make hypermobility of the ulnar nerve to be more important than it was in the past. Lucas mentioned that usually this entrapment syndrome is mostly found in the fifth decade, but for instance, as I showed you, my patients were all in the third and the fourth decade, so significantly younger than what mentioned in the literature so far. We also have to consider, as Crescenzo mentioned at the beginning in the first presentation, that it seems that the use of electronic devices like smartphones seems to have been correlated with an higher incidence of this pathology, and this is definitely confirmed in my experience. There is evidence in the literature that probably hypermobility might also be related to more severe clinical presentation. we definitely need to know whether this condition is present, and therefore dynamic ultrasound of the ulnar nerve should always be included in your diagnostic assessment. If you found out that a patient presents an hypermobility of the ulnar nerve, I would recommend that you do not consider simple in situ decompression as first choice. And personally, I believe that even in those cases that hypermobility of the ulnar nerve has not been preoperatively documented, you might consider that choosing anterior subcutaneous transposition versus simple in situ decompression might be something that prevents the onset of a iatrogenic hypermobility, and therefore you might prevent the recurrence of symptoms and the possibility for a revision surgery. I do hope my presentation was clear enough, and I thanks for your attention.
Thank you very much, Deborah, for this clear statement and presentation. I think we should move forward for the last speaker, but just I would like to encourage again the audience, please write down in the chat your questions so that we later on can discuss everything. So right now I'm able and very happy to introduce Kartik Krishnan. I think we will see right now very, very nice and small incision. So Kartik, I'm looking very forward.
Thank you very much. I hope everybody can hear me. I just want a feedback that you can hear me. Just give me a
We can
shout.
perfectly hear and see you, Kartik. Thank you.
Oh, thank you very much. So I was given the task of talking about the ulnar nerve entrapment of the elbow, the role of endoscopy. This wonderful seminar. Much has been already said, so I'm not going to go into the details of the diagnostics and the epidemiology and so on. I'll just focus just on the endoscopic part of the deal. So there are, when it comes to endoscopy, there are two techniques that are used for nerves. The first technique is the so-called bougie technique. Bougie means to dilate. Use a bougie to dilate a space and introduce the endoscope into the space which you have dilated and perform a release. And the salient features of the bougie technique are dilate the nerve canal, introduce the endoscope into the canal, and perform a release with an inline view. That means you don't view the nerve itself, but the structures which you're going to be decompressing. The retractor technique is you dilate the space around the nerve canal, or for that matter, anything, and introduce the endoscope into the stent which you have created of the soft tissue and perform the release. You have a bird's eye view of the structure you're going to manipulate, and yeah, you cannot, you need supple tissue. You need the tissue that is elastic and nice and allows itself to be raised like a tent. You cannot operate Ironman with that, sorry. So this is a schematic representation of the bougie principle, where you introduce, you can see a facial band. Let me try to, well, there, over there, this is the canal where the nerve is encompassed in the facial band, and you introduce the endoscope into this canal and use a knife or any other device to cut the facial band, which happens to be on top of the endoscope, whereas you see the endoscope itself views the band, views the ligaments, but not the nerve itself. You see, as opposed to that, I got the wrong picture. I'm sorry. So as opposed to that, the endoscopic, the retractor view is you introduce the retractor endoscope on top, and you have a bird's eye view. You will, I'm sorry, this is a wrong picture, but you will get to see the technique in the by and by. The salient differences between the two are: in the bougie technique, you dilate a cramp space. In the retractor technique, you do not dilate the nerve canal itself. Bougie technique is limited to decompression only. Retractor technique, you can use any other surgical instrument. You can use it for transposition and harvest. In the bougie technique, you use a knife, only a knife. And the bougie technique is limited to certain anatomical sites, whereas the retractor technique is quite universal and is not limited to anatomical sites. So the bougie technique is basically limited to nerves only, whereas the retractor technique is not limited to nerves. So this is the bougie endoscope, where you can see this is like a pistol where you enter the nerve canal with the pistol and cut whatever is lying on top of it. So the nerve itself is not visualized. This is an example video of the bougie endoscope, bougie technique. You make the incision, the carpal tunnel, and you introduce. So far it is all done. That is a blind manipulation where you manipulate with just the feeling, and then you introduce different kinds of bougies to dilate. And then you introduce the gun, the bougie endoscope, the AG endoscope, and cut. You see the nerve itself is located somewhere below endoscope itself and not visualized. I'm sorry, I had to repeat that. I wanted to show with a pointer, but somehow it's got repeated. So there, it is being introduced, and it is being, so the nerve is, if you see the top left corner, the nerve is located below, and the endoscope is able to visualize only the ligaments, and at a very, very close up. And there, you can nicely see the fat tissue. The ligament has been cut completely, and the fat tissue comes in and bulges into the canal, which is, and again, the same technique is used to do it proximally, to dilate the canal, as you can see. And this is basically a blind manipulation. And then there, let's see. And then the whole site is lavaged, irrigated. So the retractor endoscopic technique is a little bit different in that you introduce the endoscope on a plane above the nerve canal itself, and you don't dilate the nerve canal. You don't enter the nerve canal with bougies or blunt or sharp instruments whatsoever. This is an example of here I've shown how you can transpose the nerve even. In this, I'm not in agreement with Shimon Rokin and also with Deborah. You have to sacrifice the first or even the first two branches of the FCU in order to transpose the nerve. Otherwise, you will not get an adequate transposition. This is number one. Number two, the pain is caused not by the transection of the FCU branches, rather from the antebrachial cutaneous nerve, medial antebrachial cutaneous nerve, which is a sensory nerve, and that is the culprit which causes severe neuropathic pain problems when it is injured. And here you can see 360 degrees neurolysis of the nerve is necessary for transposition, and after that you can see that the nerve has been transposed nicely into a cubital fossa and a cubital a pocket created in the cubital fossa, and stitches placed between the deep fascia and the subcutaneous tissue as shown here will create septum, and that is the original course of the ulnar nerve, and that is the new course of the ulnar nerve. And we have to see that it is not being done with kinking. During the surgery, you have to move the elbow completely and see that the nerve does not kink after it has been moved. We did some studies comparing the open techniques and endoscopic techniques. In this study, we compared only the in situ. I showed you the I showed you the anterior transposition just for the gimmick, just to show you that this is possible with the endoscope, not to show you that this has to be done. That is a completely different issue, what we do, and whether you transpose or not, whether you transpose subcutaneously or subfascial, or you remove the muscle and put muscle, or you remove the medial epicondyl. These are discussions which are strategic discussions. Here, I just wanted to show you the endoscopic technique where you can really do it with endoscopy if you want, if you have the dexterity. And we compared two cohorts of patients, equal cohorts of patients which have been operated in the endoscopic technique and open technique. And you can see after 2 years, there is absolutely not big difference between the outcomes. You know, both groups showed excellent outcome, and most of the people, 60% of the people showed excellent outcomes in both groups. So there is they are comparable. But what is interesting is the time to post-op return to full function in the compared groups is much higher in the endoscopic group. That means that the postoperative pain is minimal, and they can they get back to work quickly, and they're mobilized quickly. An important thing here is also to mention that the proper implementation of the technique is important. You know, in good hands, any technique is good, but like Lucas mentioned, Zager KISS is the best option. I mean, keep it very simple, keep it straightforward. In conclusion, I want to say that the long-term results don't depend at all on the technique what we use. Short-term results are better with endoscopic releases. So let's come to see the endoscopic technique as a surgical tool required for certain indications. So all around the world, there have been many surgeons had used endoscopic techniques to achieve different goals. And how will you gain expertise if you don't use it? So using it, the best to begin with simple procedures as in situ decompression of the ulnar nerve. This gives you a fantastic bird's eye view and an opportunity to use the endoscope and decompress it. And when it comes to the once you have gained the expertise in using the endoscopic tool, you start to see the indications when you need to use the endoscope, where you can use it, or not as an endoscopic technique as a strategy, but use it as a tool. You know, if you need a scissor, you use a scissors. If you need a rasp, you take a rasp. If you take a dissector, you take a dissector, or Leahy, you take a Leahy. Same way, whenever you see there is a necessity, you take the endoscope and use it for the indications as you see in history. Thank you very much. I'll keep my talk minimum.
Yeah, Kartik, thank you very much for this excellent overview and for reminding us that endoscopic techniques is an enhancement of what we have to treat these patients. So we now will start the discussion. There's one question or two questions from Dr. Gavrilins. He asked, arm surgeons usually use maximum decompression technique, decompression all possible compression sites, not only cubital. Is this necessary or not? So go, as was proposed when introducing the endoscopic techniques, the argument to do it was to have a long distance decompression for about 10 to 12 centimeters, starting at the cubital tunnel, proximal and distal. And that has now over years been reduced to, well, more or less the cubital tunnel plus maybe 5 to 10 centimeters. So this is the first question, go for all. And the second is, what is your opinion of combination when decompress the nerve to augment inside the cubital canal formed by a muscle roof attached to the medial epicondyle? Does it help from instability? So basically to prevent secondary hypermobility after in situ decompression. So what's your opinion on this? Kartik, will you want to start?
Yeah, thank you very much for the stimulating questions. The comment to the first question is, there is no necessity to decompress the nerve in a very, very long stretch. it was the studies which were presented at that time was just to justify, it is quite a natural thing, just to justify their new technique, a new tool which has been brought into the scenario, and to say that, look, this tool offers something which, if you want to do in an open fashion, you have to open up a very long distance. And they tried to impress upon us and saying that, look, with the endoscopic technique, you can really decompress in a long distance without making a long incision. And this is necessary. This is actually necessary to do the decompression. But I personally, also studies have shown that it is not really necessary to do the decompression at such a long distance, is number one. Number two, double crush and other issues have been brought up, both by Shimon Rockin and also by other panelists, about whether to operate the double crush right away. If there is a Loge de Guyon and a cubital tunnel syndrome, do we need to do it both? Yes, I would. If it has been electrophysiologically tested and proven, as well as there is Tinel sign on both sides, and the patient has atrophy of the hand intrinsics, then I would go in and do. I will go even one step further, and I will tell you a short anecdote of my fellowship with Dr. David Klein. He visited us when I was in Gießen, and we operated together a case of a huge lipoma of the forearm in the volars aspect. So I removed the lipoma. It was quite a straightforward case. But then David said, go on and decompress the distal part of the carpal tunnel. It is always, because once you do such manipulations, the distal part is going to swell up, and there are going to be some tissue swelling. And he found it necessary that a distal decompression is important, especially when you do manipulations. So I also advocate this to our trauma surgeons when they put in plates in the distal part of the radius. It is rather a good idea to go and decompress the carpal tunnel in order to prevent postoperative carpal tunnel syndrome and worsening the nerve conduction possibilities. I hope this answers all the questions, and I hope I'm forgotten.
Well, the other question was the creating somewhat like an obstacle to have hypermobility after simple in situ decompression. I personally would completely refrain to do it because of the scarring, because you need to cut a muscle and suture it, so you will create scar, and you will create most probably a secondary, or at least there's the risk of creating a secondary compression side.
If it is going to subluxate, as long as it does not create clinical problems, it doesn't matter. It can't even subluxate. As long as it doesn't snap, there is going to be some movement, as shown by Giovanni Cocco, that the movement is always going to be there, because nerves should glide. So that also brings us to the issue that soon after the surgery, we have to mobilize the joint. We have to get the patients moved. So the thought that we have to put the elbow in a cast, like many orthopedic surgeons do in our area, this is outdated, and it is not correct. It even injures the nerve. When the nerve gets tethered in its new place with new scarring, that's going to create more problems. So that's why I encourage my patients to move the elbow, to do the physio right away.
Absolutely agree. So thank you, Kartik. So one of the, I think one of the most controversial statements was by Deborah, and this was again the idea to come up with this webinar is to, there are even guidelines, at least in Germany, for the treatment of cubital tunnel syndrome, and most of the work is based on one of the most experienced peripheral nerve surgeon we have here, and he has done thousands of ulnar decompression, which is Hans Asmus, and he basically came back to the Zager principle, to KISS, to keep it as simple as possible. And and this is what we, even with literature and with all the experienced colleagues involved in the generation of the generating of the guidelines, agreed that even if the nerve is hypermobile, we will not go at first sight for transposition. So this is maybe some 7-8 years old. And Deborah stated that in her, according to her experience done in the UAE, that her way to treat changes. So is this something that is true for others too? Deborah, please.
Okay, so the experience I presented, it's a partial experience because I just focus on the patients that I have diagnosed and treated in the last year. And maybe because, you know, you always try to keep the presentation as short as possible, I have not indulged in saying that I also, of course, have performed a simple in situ decompression as first choice technique for many years. And I just started to change my technique more recently when I started to see that the percentage of patients presented an hypermobility of the ulnar nerve was relevant. And again, maybe we also have to consider what is the lifestyle of the patients. Young patients are using a lot the smartphones, which means that they spend a long time with the prolonged elbow flexion. And as I mentioned, also, most of my patients were young males, and I might even say kind of rather obsessed with being fit, and therefore weightlifting was a major concern for them. It's probably a small sample of the population, but one thing is clear, patients with a different kind of lifestyle with those that I used to treat, for instance, when I was in Italy or even years ago. And I think the point, and this was my message, I think we also have to say, so update the technique, and we have also to consider that we have to tailor our procedures based on the new conditions of the patients. I can tell you that most of my patients report, doctor, when I keep my elbow flexed, I see that immediately I have a worsening of the algoparesthesias. So there is a clear also evidence that, and I can hear the click of the nerve. So, you know, this for me is an evidence that the ulnar hypermobility is not a situation that we should underestimate. For sure, we need more evidence, but I think we have to consider that most of the reports in the literature also date back to before we started to do an assessment that would include electrodiagnostic studies and imaging. So the hypermobility was probably not preoperatively assessed. There was a different lifestyle. So, you know, for me, I'm not saying that I want to oblige everybody to go for anterior subcutaneous transposition as first choice, but I think that probably we have to consider there are new conditions, and maybe we should consider that what was valid as a statement 15 years ago might not be valid anymore now.
Thank you very much. I think this is very important to point out that the dynamic studies, especially with ultrasound, give us insight into pathologies we not have seen this way before. So what I ask myself is the hypermobility the actual problem? Because you can see an epineurial scarring at the point where the nerve, let's say, rubs around the medial epicondyle, or is the anterior transposition, as you showed, Deborah, in your presentation, that the nerve is less stretched once you flex the arm completely, if it runs around the cubital fossa, or if it's transposed. So is it also a problem of less stretching of the nerve? Is there any opinion on that?
Yeah, I think that this is also one of the major reasons why these patients also do better when they have the anterior transposition. For somebody that spends, for instance, 10 hours typing on a computer, and therefore with prolonged elbow flexion, or for instance, if they have the habit of sleeping with flex elbows, the stretching might be a major factor triggering the onset of the symptoms, and the transposition has this advantage as well.
So there's one more question from Dr. Zitek. This goes for Kartik mostly. Any conditions that prevent using endoscopic technique to use, Kartik? Is there anything, condition you would say, no, in this case, I will go for open?
Actually, again, I'm coming back to my comment about using the endoscope as a tool. It is not an endoscopic technique of transposition. So you can basically begin any surgery with an endoscopic approach. And as soon as you see that the scarring is too high, or there's going to be additional pathology which are not going to be approached with the endoscope, you can either do a second incision and go on from that part using the endoscope, or you open up. So scarring and additional pathology. For example, many years ago, Shimon Rotkin presented a fantastic video in one of our meetings where he showed how he used the endoscope to detect shrapnel injuries down a nerve when his exposure was limited to one area. And that is something which I would not take out shrapnels located in far areas using the endoscope, rather open and do it under sight. This is something which is important to me. So scarring, additional pathology, these are the two basic indications where I would switch over from endoscopy to open procedure. And don't shunt to do that.
Thank you, Kartik. So are there any comments on this from the panelists? And there's a comment from Dr. Forster. Imaging studies in neurophysiology pre-op and in theater showing nerve function and localized entrapment focal damage. Klein showed the value of this years ago. Any current uses? So any intra-op monitoring during ulnar nerve surgery? And Klein would show exactly where the conduction would have been compromised. But this is true. This technique, I guess, is really rarely used. So I personally, in the ulnar nerve surgeries, I use the stimulation, but not monitoring. So no NAPs and no SCCPs or anything. How about the others?
Same thing for me.
We generally use intraoperative electrophysiological monitoring practically for all kinds of peripheral nerve surgery, and especially, of course, for ulnar nerve entrapment or another kind of entrapment. It's very helpful. It's helpful for us to clearly understand if it's completely released. You know, in situ release is simple release. Everyone can do this, but it's not so simple. Very important to release in 3 points of the possible compression, or to be sure that it's completely free. And electrophysiology help during the surgery to understand if you release of the nerve. In most of the cases, you have intraoperative improvement of electrophysiological response directly. Of course, you need good electrophysiology specialist, because it's difficult for a surgeon to do also electrophysiology and also to operate patient. But intraoperative electrophysiology is necessary. Practically, and also is, you know, in last 30 years, excluded maybe few separate cases. I don't operate any case with anterior transfer in case of ulnar nerve, pure ulnar nerve entrapment, not traumatic and not iatrogenic and not residual. Of course, I completely agree with Deborah. In cases of traumatic injury, in cases of iatrogenic injury or residual, is in most of the cases necessary to perform in a anterior transposition. But in pure, in the first surgery, is direct decompression, delicate direct decompression with intraoperative response, with good electrodiagnosis before surgery injury, and of course ultrasound observation is necessary. Because I would ask for a panel case, young men have clinical picture ulnar nerve entrapment, ultrasound normal, EMG normal. He suffered in last 6 months. Is he have a problem with quality of life? His spine is no problem. Is MRI is normal. no problem. You have a clinical picture with sternal, not atrophy, hypoesthesia. So what you're going to do with this case? EMG normal, ultrasound normal, only clinical picture, 6 months, no improvement.
I would go for surgery.
Well, in situ for my side, surgery.
Yeah.
Simple in situ decompression.
Yes, I completely agree with you. This is a patient, try all kinds of medication, is a swimming pool, not any psychological problems. After surgery, dramatic improvement in his condition. In situ release, of course.
What we left out was the revision surgery, which is, I think, a huge topic in ulnar nerve, because we all know the cases of people with ulnar nerve that have been operated on twice or even 3 times, and there's has been an anterior subcutaneous transposition, so there's also scar tissue, same as for the cubital tunnel. So David Klein was already mentioned, and Learmonth too, with a submuscular transposition. So is this limited to secondary procedures? Because I know that Dave Klein, with quite a success, used it for primary too. I remember when Thomas Kretschmer came back from him to Günzburg, he introduced this technique, and the people were happy with it. Although they need, of course, a longer time to regenerate because of the more invasiveness. Kartik, please.
You see, the thing is, I just keep coming back to this issue again and again. It is the action between the technique and the strategy, what you decide. So I have seen many a times patients who come to me with a very small incision where they say there have been anterior transposition of ulnar nerve having been done, and you see obviously a killing of the nerve. The nerve has not been released proximal enough. The nerve has not been released distal enough, and the transposition was just nothing but a worse kinking of the nerve just around the epicondyle, around the medial epicondyle. This is something which has to be, so if you put all these patients into that basket and say that anterior transposition, is it good or bad? It is bad, of course, it is bad. So if an anterior transposition has been properly made, or an in situ decompression has been properly made, then the results are going to be different. So we cannot label completely and say that anterior transposition is bad. It doesn't work.
Absolutely agree. So I think what we all need to keep in mind is that even if it doesn't seem to be complex surgery, but what we learned during this webinar is that we can do a lot of harm if we are not working in a meticulous way in all levels. So I think whenever a technique is well performed, the patient most probably will benefit from it. And of course, we need to choose the less invasive one with the best effect. So I completely agree to not, stigmatize one of the techniques, but to keep in mind all of them and pick the right choice for every patient. So I would like, if there are no more questions, I can see the
new
Q&A.
paradigm shift. I don't agree with Deborah. We have these things nowadays. These things. People use the earphone. They don't do that anymore. They don't do that anymore. Maybe some people sleep like that.
We'll see. But let's have one. We can repeat the webinar in 2 years and see the effects of the earpods.
Absolutely.
Sponsored by Apple and Samsung.
Or maybe Corona.
Deborah, please. You want to make the final remarks.
The final remark is that we all only wanted to prove that ulnar nerve entrapment is not such a simple pathology as many believe. The fact that already we have so many surgical techniques, and at the end of the day, quite a few surgeons are discussing, and we do not find an agreement on which technique might be the best one, probably implies that still we have to learn a lot. My personal message was that we, as I said before, we really need to tailor the diagnostic assessment and consequently the indication for surgery. Maybe there is something which is changing in comparison with the past. And probably we still need to review the results also with longer follow-ups that we did before. And I agree with you that we should have included also the revision surgery, but we had limitation related to time, and this is the reason why at the end of the day the main message was about the diagnosis and the indication. But since it seems that the topic was interesting for quite a few of the participants, maybe we can actually do a second part and rediscuss some of the concepts that we already mentioned today, and also analyze them at the light of the revision surgery.
Perfect. So we will conclude this webinar. So thank you once again, Deborah and Shimon, and Anna,
thanks to everybody.
And all the speakers involved and all the participants for the fruitful discussion. And we will keep you updated for the next activities with our webinar series, which will be in more or less 6 weeks, 6 to 7 weeks. So good night and see you next time.
Good night,
Thank you very much.
Right.
Good night.